I will dissect graft cases step by step. Those are practical cases, that we see every day. I will start with this standard case. This is a man with a 3-vessel CABG 5 years ago, LIMA to LAD, vein graft to OM, and vein graft to PDA, right PDA. He's coming with recurrent angina. So I will explain how we did this case. We started this case with a femoral access, although we can also do left radial access, and I will show that toward the very end. So we started with a femoral access, and we start typically with a native angiogram, and we derive a lot of info from the native angiogram. Every step of the way, we try to map the perfusion of the myocardium. And we start that via the native coronary angiogram. I typically take 2 shots of the native arteries. I try to limit contrast in those cases. So we usually do, instead of 4 or 5, two native views. I typically do, my 2 most important views in general are RAO caudal and shallow RAO cranial. And those are the 2 views I take. So this is the first view in this patient. So this is the RAO caudal. I will go over this quickly, but you already notice a couple of things on this native angiogram. One, this is RAO caudal, so the circumflex territory should be here. You notice there is no native circumflex territory. That's one. 2, regarding the LAD system, always beware when someone has CABG. What you see in this area is probably, as your reflex, it should probably here not be an LAD. By definition, somebody who had CABG, he probably has either an occluded or severely diseased LAD and a graft to the LAD. So the native angiogram should not show you an LAD typically. So most often what you see in this area are a bunch of diagonal. This is beside the fact that we know diagonals run on the border of the heart shadow in this view anyway, not the LAD. So on this native view, you already see a few diagonals, most likely in occluded circumflex. Look for the LAD. I see it myself. I see it here. It's more in the center, and it's occluded. You already notice there is competitive flow, and that's something you should look forward to see on the native coronary angiogram. You also see another thing. You see late filling. Whenever you're analyzing native coronary angiogram in a CABG patient, those are 2 big things you always look at. Competitive flow in a native vessel and late filling, which suggests an occluded branch or an occluded vessel. You see competitive flow in the LAD. You see late filling of an OM branch. So those are already 2 ideas you see here. And open diagonals. Then we do the shallow RAO cranial. And here you see that will lay out very well the LAD system. And here again, your eyes should catch this competitive flow, this to and fro flow in the distal LAD. There is an old stent in the distal LAD, and there is a likely subtotal occlusion past that stent and a little before it as well. So you can imagine, so already by looking at this, you know the LIMA to LAD must be patent. You don't know how diseased it could be, but you know it must be patent since you have that competitive flow. So that's already one piece of information you get from this. You get another piece of information. Since there is a probably severe disease, that LIMA to LAD is not feeding the proximal LAD, is not able to flow retrogradely in the proximal LAD. So that whole segment of the LAD is being fed by the native LAD. Hence the importance of that native segment for supplying the first diagonals and septals. And that can cause ischemia if you have disease in the proximal LAD, even if you have a patent LIMA. And I will go over that a little later as well. Okay. Now, what does the collateral filling? Again, this is a patient who has a graft to the OM, and you're already trying to map his anatomy. So you have collateral filling to that OM. What does this imply in regard to the graft to OM? You're already starting to think here. Is that graft to OM occluded? Evidently, not necessarily, although that is a possibility. So you have to already imagine this. This is his anatomy. You have multiple OMs. You're seeing one OM filling late, but that's not necessarily the OM that is grafted, but you're already thinking about it. It could be that he has another OM that is grafted, OM2, for example, and his OM1 is occluded and is not grafted. And therefore, it is ischemic and it's relying on collaterals. We will further elucidate this as we go through the angiogram, but already keep those ideas in mind. So after doing the native left coronary angiogram, here I'm using the Judkins right 4 to do the native right coronary angiogram. This is the LAO view, and this is the epicranial view, which I use to see the distal right. So already you see here the native right is open and it fills some posterolateral branches or maybe posterior descending artery. Again, think of the patient's anatomy. He has a graft to the PDA. You don't see any competitive filling. Is this graft to the PDA occluded? If you want to guess, already by looking at this, is his graft to PDA occluded? So start thinking about this. You can try to answer that.
Most likely.
Okay, so that's a possibility as we were doing it. I did not think that's most likely for a couple of reasons. One, you know, those branches you see are too small to be bypassed. They don't extend beyond half of the heart margin. So what you see, or beyond half of the LV length. So those are most likely small posterolateral branches. Most likely those are not the bypassed vessel, the bypassed PDA. Probably there is a PDA here that is longer that is being bypassed and that is occluded and disconnected from the native RCA. Most likely. Now, if indeed those are bypassed, then you can tell, well, the vein graft to RCA is occluded. But always keep in mind, we probably have another one bigger that is bypassed and that is disconnected from the native RCA. I'll show you this illustration. So most likely what we're seeing here, we're seeing this and this. The true PDA is occluded ostially and it's disconnected from the native right and it's dependent on the graft, okay? Most likely, we will have to prove whether that's true. Now, if the graft turns out to be occluded, then maybe, yes, one of those was bypassed. And because the native vessels are small, the graft eventually occluded. So it's a possibility, as you see this with no competitive flows. Either the graft is occluded or most likely the graft is to an artery, a PDA that is disconnected from the native right. Did everybody understand those concepts? Again, you're thinking through this as you're doing the case. Everybody understand that? Okay. Now, after we engage the native left and the native right coronary, now we have to move to engaging the grafts. This is a very important picture to keep in mind each time you engage a graft. You have to memorize it, keep it in your pockets. It's the basic graft anatomy. You have 3 sets of vein graft or radial grafts. Graft to the right, to the diagonal LAD system, and to the OM system. And there are 3 ideas underlying those grafts. Down to up, you have graft to the right, graft to the diagonal LAD, then graft to the OM. Right to left, again, graft to the right, diagonal LAD, and OM. Then the morphology of each graft. Graft to the right is pointing down. Look at it. If you're trying to engage it, you have your catheter has to be looking down. Graft to the left, especially graft to the left OM, is pointing up. Okay, so that's those are very important 3 ideas and pictures to remember as you're analyzing, as you're doing the case. One important implication of this is which view to use when you're engaging grafts. So in order, you have to always get a view that's orthogonal to the osteum you're trying to engage. So you can already tell for a graft to the RCA, you need an LAO view. For a graft to the left coronary branches, you need an RAO. RAO will be orthogonal to those. So it's opposite to the vessel. Graft to the right, it's LAO. Graft to the left, it's RAO. Okay? And this is a further illustration. This is another patient, but to show the concept. This is an LAO view, and we have circles around those grafts. This is a graft to the RCA, you have markers. This is a circle surrounding the graft to the RCA, and this is a circle surrounding the ostium of the graft to the OM. And you can see in LAO view how you're orthogonal to the graft to the right, whereas the graft to the OM in an LAO view, it's looking at you. It's hard to engage a graft to OM in this view because you have to make it look at you. In this one, you can lay it out perfectly and make it point toward that circle. It's actually best to make it, to make that LAO view very much orthogonal to that graft, so much so that that circle becomes like a line. This is when it's easiest to engage it. You make that circle a line. Conversely, in RAO view, the graft to the RCA, RAO, graft to the RCA is looking at you, whereas graft to the OM, the ostium is well laid out and you can engage it, okay? So when we're planning to engage a graft, quickly in our minds, we need to go through 4 steps. So one step is which view, which I explained. A second step is which catheter to use. And that relies on the prior idea I described, is what's the morphology of that ostium, pointing down or pointing up. The third idea is how to torque, counter or clock torque. And the fourth is which views to use to image that graft. So let's go back to our patient. And so we're trying to engage, he has 2 grafts. He has a graft to the right and graft to the OM. I have a JR4 in my hand, the Judkins right, which I use to engage the native RCA. So which catheter will I use to engage each one of the grafts? And, can I use the JR4? JR4 that I use to engage the native right is, in my opinion, not a great catheter to engage the graft to RCA because it's pointing too much up. You can engage it, but contrast will swirl out and you end up missing the filling of the graft and think it's occluded and that it has a stump. I've seen several of those cases. So I try to avoid doing graft RCA angiogram with a JR4. It's better to get a catheter pointing down, and I'll mention later some of those, like a multi-purpose catheter, my preferred catheter for that. So I have the JR4 in my hand. Can I use it to engage the graft to OM? I do. So, and that's how I proceed with those cases. I engage the native left, native right, then I engage with the same JR4 catheter, the graft to OM, graft to diagonal, if the patient has a graft to diagonal, and I use the same catheter to engage the subclavian for the LIMA, okay? So in this case, I went straight to try to engage the graft to OM. And because it's a graft to the left, I use an RAO view. This patient has markers. So you see in an RAO view, the graft to the right marker is looking at us. The graft to the left, to the OM, is being laid out very nicely. But this RAO, it's not well laid out. So this is RAO 30. So we went steeper RAO to again try to make it look like a line, like a flat line, okay? So it's easier to engage it. It's that a flat line means you're exactly orthogonal to it, so you point your catheter straight into it, okay? So we decided on those steps. The view to engage for that graft to OM is RAO. We decided to use a JR4 catheter. Now, how to torque to engage? Anybody can tell, is it clockwise or counterclockwise torque, generally speaking? I want you to think and memorize it here.
Clockwise.
Yes, excellent. It's a clockwise torque. Clockwise torque in general with a Judkins right 4 makes you point a little more anterior, and that's the case of those left grafts. In general, it's clockwise torque, although, you know, again, it's not a definite rule. You may have to try in both directions. The key is, again, to make your catheter point directly in that direction. So do whatever is necessary to point it in that direction. Also, you have to pull, push. Sometimes you counterclock low and you pull up and clock. One of the difficulty in engaging this is making the catheter reach that wall of the aorta. Sometimes the catheter stays center. So you do whatever torque to elongate the catheter and make it point and touch that wall, okay? So clockwise torque. Then after we engage it, then the fourth step is which views to use to image it. So I'll give you general rules for graft. There are two main views for every graft. One view is the view that you use to engage it, which is in my case, RAO for the left graft and LAO for the right graft. LAO straight and RAO straight, the views used to engage it. That's one. That will generally show you the graft itself, the graft ostium, evidently, since you use it to engage that ostium, and the graft body. That's one. Second view I use is a view that's good to that native in general, and you need to know what views are good for the native. For example, graft to OM, generally I would use, beside an RAO view for the body, I would use maybe an AP caudal or an RAO caudal. This is the view that's good for the native OM in general, okay? Graft to diagonal, I would use, again, RAO view for the graft itself, and I would use probably something like AP cranial or shallow RAO or shallow LAO cranial to see the diagonal itself. Generally, the view that's good for the native is also good for the anastomosis. Okay, so two basic views, the straight view used to engage and the general view that's good for the native, which often shows you the anastomosis as well. Okay, so this is the RAO view that we used to engage. We see the body of the graft well. It has disease. It has diffuse atherosclerosis, moderate at the ostium, some moderate disease around the previous valve in the vein graft, in the vein itself. The anastomosis is seen well, and you can see the OM runoff here. Try to take another view here, and that shows you a caveat. I took an AP caudal, which is generally good for OM, but we don't see it well here. Anybody knows why we don't see it well here, the OM itself, and what view to take to improve seeing that OM? This is the AP caudal. In general, the caudal views are good for the OMs, but they are not so good when the OM is very distal or almost like a posterolateral branch. The more distal your OM and posterolateral branch or a dominant sarc with a PDA, the more you have to go actually cranial to see those branches. And that's the case here. It's a very distal OM. So we end up doing a cranial view to see it. Oh, sorry, here. This is a cranial view, RAO cranial view. You can see the ribs are going down. You see the diaphragm. This is an RAO cranial view, and it shows very well that distal OM. It shows very well its anastomosis. Okay. So now we engage the graft to OM to go back to the steps of our case. So we engage the graft to OM with the same Judkins right 4. Now we still have LIMA to LAD and graft to RCA. I decided this to keep it till the end, the graft to RCA. Now, how can I engage the LIMA to LAD? What are the steps in engaging the LIMA to LAD? Two steps, okay? Engaging the LIMA to LAD, remember the LIMA to LAD is an in situ graft attached to the left subclavian and connected to the LAD. So two steps always. One, how to engage the left subclavian, and two, how to engage the LIMA itself. So the first step, how to engage the left subclavian. Again, I have a JR4 in my hand. I think the JR4 is a wonderful catheter to engage the left subclavian. So the same catheter that I used to engage the native RCA, the graft to the OM, will be used to engage the left subclavian. Then, as in any graft, and in this case, the left subclavian, you have to think through those steps. So what catheter? We agreed the JR4, that's in my hand. What angle will show you how to engage the left subclavian? So the angle is, and here I show it well, is an LAO angle. And you can see through this. This is the aortic, ascending aorta and aortic arch. LAO opens well the aortic arch and the supraaortic vessels. It lays them out well, so you can engage them. RAO, on the other hand, superimposes the ascending and descending aorta and superimposes all three vessels. So you don't know how to point your catheter. And you don't know when you are in the aortic arch in RAO view. So you have to do LAO view. This is how RAO view will look like. Sorry. This is how in RAO view, it will superimpose ascending and descending aorta. It will jumble everything together and all supraaortic vessels together. You don't know where to point. LAO opens them up and you know how far to pull back to get in the subclavian. RAO view, you can engage the right innominate and think you're in the subclavian. You cannot, left subclavian. You cannot tell. So you have to use an LAO view to lay those out and know how much to pull. Okay. Also, LAO view will help you through the shape of the catheter, help you know what's the morphology of this aortic arch, how steep it is. And I'll go back to this a little later. So you do LAO view and you know the left subclavian is the third vessel. It's toward the end of that horizontal portion of the aorta, aortic arch. Now, what maneuver? Again, the third step in those steps, how to torque. So we decided JR4 for the left subclavian, LAO. Now, how to torque? This is one of those you absolutely need to memorize. I ask sometimes third-year fellows and they give me the wrong answer. Is it clock or counterclock? You absolutely need to memorize this. It's counterclockwise. It's always counterclockwise rotation. It's one of the constant here. So you pull with a counterclock so that your counterclock gets transmitted as you're pulling, somewhere in the range of 90 to 180 degree. Okay. I want you to know this idea. It may seem if you take a catheter and put it outside the body and clockwise torque it 180 degree, and then, or counterclockwise torque it 180 degree, the catheter will reach the same point. Okay, it's 180 degree. You will end up reaching the same point, whether you go counterclock or clockwise torque. That's not true inside the body. In a three-dimensional, across the tortuosity of the arterial system of the body, in a three-dimensional view, 180 degree counterclock of a catheter will point it totally differently than 180 degree clockwise torque of the catheter. In this particular case, counterclock rotation will point the catheter a little bit more posteriorly, whereas clock will point it a little more anteriorly, which wouldn't work for the supraaortic vessels. I will show in another slide later also, I'll illustrate that concept, that how 180 counterclock is not the same of 180 clock. If it was the same, our life would have been very easy because you can do whatever you want with the catheter and it will reach the same point. But our life is not as easy. That's why you need to know those ideas. So counterclock always to get the left subclavian. So I use a JR4, we pull with a counterclock, as you will see here. This is how we did in this case. So we're pulling the JR4 with a counterclock and it falls. It fell at the end into the left subclavian. Now, one thing that happens at times, it can fall into the carotid or sometimes in the right subclavian. It can fall here or it can fall there. So what do you do in this case? One standard technique is that you reverse the torque. You clockwise torque it to make it fall down. Then you pull again and counterclock to hook the left subclavian. So you reverse it, make it look down, then you pull with a counterclock to hit the left subclavian. Another technique is, if you're hooked in one of those, is to pull it straight in that direction and get into the left subclavian. It is generally advised not to do that technique because you don't want to scrape atheroma from the aortic arch and embolize and cause a stroke. In general, though, the risk is very low, and in a difficult case, that may sometimes be the only thing and the most expedite thing to do, to just pull it straight and get in the left subclavian. Again, that shouldn't be your first line approach, but that sometimes is something we have to do. Did everybody understand how we can get out of a carotid and get back in the left subclavian? Now, after we get the left subclavian, what is the next step? So we got that catheter in the left subclavian. The next step is to get to the LIMA, which is here. And how do we get to the LIMA? So we finished getting the subclavian. Now we're thinking of getting into the LIMA. So we have to advance a wire, an exchange length wire, and exchange that JR4 for an IMA catheter or an IM catheter. JR4 is not the best catheter to engage the IM, the LIMA. So after we get to the left subclavian, we advance an exchange length wire, and we take that catheter out and advance over it an IM catheter and try to engage the LIMA. This case, it was easy to advance a wire. There are a lot of cases in patients who have calcified and tortuous subclavian, where you're not going to be able to advance a wire that easily. In that case, one, you may need to advance a glide wire, which is a slippery wire. Two, you may need to advance the catheter and wire simultaneously, meaning you advance the glide wire as far as you can, then you advance the catheter as far as you can to support that glide wire, then you further advance the glide wire, then you further advance the catheter, and you kind of try to embrace the morphology of the subclavian, giving yourself support and pushability with each step, okay? So glide wire and further push of the catheter may be needed in difficult cases. And after you get your catheter up, then you put a standard catheter, a standard wire like a J wire or a supportive J wire, and you exchange for an IM catheter, okay? So all this to get to the close to the LIMA with an IM catheter. Now, what's the next step? So we got a catheter around this area. How do we engage the LIMA itself? That's the second big step of LIMA engagement. Again, the same ideas here. So one, you have to decide which catheter, two, which view, and three, which maneuverings. So catheter, we agree, IM is usually the best catheter because IM in this position is a catheter that points most down and can embrace the ostium of that IMA. You can try JR4, but it's usually not the best. There is another catheter that points even more down than IM. It's called BC catheter, and you can try that as well. So we agreed, we got the IM catheter. Second idea, how to actually engage the LIMA. What view? So LAO view opens the aortic arch very nicely to get to the left subclavian. You can use the LAO view to engage the LIMA. However, in the LAO view, the LIMA itself is looking at you here before diving down. RAO opens the ostium very well, but you don't need to do that. You can stick with the LAO if it's too hard for you to remember too many details. I generally move to shallow RAO or AP to engage the LIMA, to see it's very ostium and make my catheter point in that direction and down. So this is the view. Three, what are the maneuvering we do to engage the LIMA? And here is what you need to know this anatomy very, very well. So regarding the maneuvering, one, you need to know that where the LIMA arises from. It arises close to the bend of the subclavian, okay? We usually position our catheter here and pull it back to engage. So it is around the bend. On occasion, it is here, and it's usually much more difficult to engage when the LIMA is here because as you're maneuvering, your catheter can fall down, okay? So that's one idea. Second idea regarding its anatomy is that it's always has that shape in relation to the thyrocervical trunk and the vertebral artery. Okay, so it's in between the thyrocervical trunk and the vertebral artery. So if you're pulling back and trying to engage it and you see the thyrocervical trunk, you know you're very close to the lima. You just need to pull a little more and make the catheter point down rather than up. Thyrocervical trunk is pointing up, lima should be pointing down. So you need to pull a little more and make your catheter point down, and you will be in the lima. Okay. Now, what maneuvering you do for that? You don't need, I mentioned again, counterclock to get into the subclavian. To get in the lima, it can be either, it's usually counterclock, slight counterclock. Occasionally it is a clock, but the idea is just know this anatomy and make it point down, whatever you need to. If counterclock points you up, reverse it and do clock. Also, if you're going from the left radial, you oftentimes need to do clock from a left radial because it's a totally different anatomy, and a clock will generally point you more anteriorly toward the lima. But again, just know this anatomy and react to what you see. Okay, this slide summarizes what I just described. Okay, is it clear? Is it clear for everybody? Do you have any questions?
Dr. Hanna, can you explain again, if you end up in the carotid, how you maneuver back to the arch? And
yes, if you end up in the carotid, how do you work your way back? Right, that's your question. So what I do, so let's say you pull with a counterclock and you fall here. You reverse it, you clock to make that catheter fall back down in the aorta. Then you pull back again with a counterclock to make it look up into the left subclavian. So you reverse it and you pull back with a counterclock. What you can do, you can reverse it, push it, basically start it over, push it down till here, and pull a little more than you did initially with a counterclock to make it fall here. If you keep falling the carotid, one of the easiest way to do it is to just pull it back and it will fall straight into the left subclavian. There is a hazard in just pulling it back. There is a tiny risk of embolization. I don't think it's a high risk. So I think it's reasonable to do if you keep failing in the first maneuver. Okay? Is it clear?
yes, thank you.
All right. Now, another thing is, let's say you couldn't get into lima, you get close to it, but you couldn't really engage it. Don't pursue trying to engage the lima exactly, especially in patients with tortuous arteries where it's hard for you to transmit the torque. And especially in patients whose lima is here. You may not be able to exactly engage the lima when your lima is here, because each time you maneuver, your catheter may fall down in the aorta, and then you have to get back into the left subclavian. So it could be a lot of labor. So if you cannot engage the lima exactly, you need to know what to do. In those cases, it is okay to take non-selective shots of the lima. The lima ostium is easy to dissect, so you don't want to pursue when it's hard. If you're close to it, take a non-selective shot. And what we do in those cases is we inflate the blood pressure cuff over the left arm of the patient. And when it's above the systolic pressure, as it's inflating at its peak, then we do our image, non-selective image. And we do a big volume. We try to do around 10 to 12 millimeter if you have an automatic injector like assist system. So 10 to 12 millimeter with the blood pressure cuff inflated here. That will generally give you good views. The blood pressure cuff will divert flow away from the arm into the lima preferentially. Okay. Since I'm talking about the lima, let me show you this here. I'll jump to this. So let's say you keep trying to engage I'll go to a case where it's hard to engage the left subclavian. This is another case. But let's say I'm trying to engage the left subclavian and I just haven't been able to get the left subclavian, much less the lima. as I'm pulling back, I keep hitting just the top of the aortic arch. I don't see any supra-aortic vessel. So what's your immediate reflex? You keep trying to pull and counterclock and you don't get anywhere. Your immediate reflex is that this is how your arch is. Most often the arch is one of those two. So you pull with a counterclock and you fall into those supra-aortic vessels. On occasion, your arch is like this. So most often you're maneuvering in standard cases into the horizontal portion of the arch, and you're aiming for the distal portion of that horizontal arch, which is where the subclavian is. But on occasion, the aortic arch is so steep that you think when you're maneuvering the horizontal portion of the arch, you're already past the subclavian and past all of those vessels. So you keep pulling with a counterclock, aiming for the subclavian here, while you're already too distal. So whenever you have difficulty engaging that subclavian, think, I'm already too distal. I should try on the ascending portion of the aorta. This is where my subclavian and supra-aortic vessels are. So you try to put your catheter here and you pull with a counterclock on that ascending portion, not on the horizontal portion of the aortic arch. That should be your immediate reflex. I struggled a lot with this when I was a fellow and even early in my career. You know, nobody had ever given me this tip until I realized it. It's a fairly simple tip. So again, this is a patient. We kept trying. No, we couldn't engage. Immediate reflex. We should try higher up. This is a type 3 arch. This part is already too distal. So we pull with a counterclock and try to engage in this area. And this is what we did in this patient. That's another patient. And look where it was. It was still, now we straightened kind of the arch with a catheter, but really it was on the ascending limb of the aorta, not on the horizontal portion of the aorta. The subclavian is on that ascending limb. Did everybody understand that important idea? That will save you in a, 10% of those subclavian cases. Okay. Remember that view, remember it very well. Type 3 arch. And you can do an aortic, ascending aortic angiogram in those cases to see where the subclavian is, rather than keep struggling with trying to engage it. Okay, in this patient, we did the LIMA, we engage it. So again, LIMA to LAD, I use one view. So now the fourth step is the views. So the view I used to engage, and it shows me the LIMA to LAD, the LIMA itself well. Then I do a view to see the native, which is good for the native. And in this case, I used an ario. We can use an ario or areocranial view or shallow areocranial. Then what is the view? For the LIMA, there is a third view. That's the only graft where you need a third view. Beside the standard view used to engage and a view that's good to the native, there is a third view that's needed to the anastomosis. And I quiz fellow this all the time, and they often don't give me the right answer. What is the standard best view for the LIMA to LAD anastomosis?
Left lateral?
Yes, please remember this, 90-degree left lateral. Now, it's hard to obtain. You have to put the arm of the patient above his head, but that's the standard view. I found that oftentimes to circumvent the need for the left lateral, straight RAO view is a very good view for that anastomosis. And this is in this patient, straight RAO view. It's showing me that anastomosis very well. So that's what I often do. Okay, to go back to that patient, so we see the LIMA to LAD filling the LAD. You're already building up your anatomy. We described his native LAD, and we can see the LIMA to LAD. It's only filling antegradely. It's only filling antegradely the distal LAD. Another thing that fellows miss when they describe a graft, including in their report, they don't describe antegrade and retrograde filling. Every graft you describe, you should discuss whether it fills retrogradely anything. So this is the LIMA to LAD. It's filling antegradely the distal LAD. It's not filling, it's filling antegradely the distal to apical LAD. It's not filling anything retrogradely. That's important because that tells you that proximal portion of the LAD, which is sitting here, is dependent on the native flow. In some other patient, the LIMA to LAD will fill all the way back. Then you know you don't care about native disease because the LIMA to LAD is taking care of it. So this is the illustration of this patient. You have LIMA to LAD filling the apex of the LAD, but then all those proximal diagonals and septals are not being filled by the LIMA, and they depend on the native left main LAD system on this. So therefore, not in this patient, but imagine that a similar patient has the same anatomy, but he has 90% disease here. Well, you can imagine if he has a lot of angina, you may need to fix that 90% to feed those diagonal and improve their ischemia, okay? So you have to already map in your brain every coronary territory, LAD, what's the graft feeding, what are the native feeding? Same for the SARC and for the RCA. Imagine another patient, he has a LIMA to LAD, but there is no retrograde disease behind the LIMA. So the LIMA fills retrogradely all the way to the proximal LAD where the disease is. So the diagonals are being fed by the LIMA. In that case, you shouldn't fix that 90%. It's useless. The LIMA to LAD is taking care of everything. But in this patient, you may need to fix the 90% because it's not being, those arteries are not being fed via the occlusion, retrogradely, via the LIMA. Everybody understand that? Always in every graft, think, what is it filling antegradly? What is it filling retrogradely? And is retrogradely dependent? Are we dependent retrogradely on the native flow? Did everybody understand this idea? I will further elaborate in a few minutes on this. Now, okay, so we discussed how to engage the LIMA, the subclavian and the LIMA. Now we go back to the vein graft to the right. So we engage the vein graft to OM, we engage the subclavian and LIMA, now vein graft to the right. So we discussed the view we need is an LAO view. And this is an LAO view. Look how the marker is becoming like a straight circle. Okay, that's how you want that LAO to be. And you aim your catheter toward that straight circle and the ostium. Now, what catheter? I discussed we need a catheter that points down. And here you need to know what catheters point down. So which catheter, which view? Those are the catheters that point down. Most importantly, I find for a vein graft to the right that points very much down, I like multipurpose 1 typically. You can use AR or what you call RCB, right coronary bypass graft. Do not use a GR4. So RCB, AR1, but most important, if you remember one, it's multipurpose catheter. Okay. All right. So now the third idea, how to torque it. So we got the multipurpose, we got the LAO for a right graft. Now LAO for right graft, how to torque it, clock or counterclock? 90% of the time I get the wrong answer on this.
Counterclock.
Yes, good. It's counterclock rotation. And I will explain, it's counterintuitive. That's how, remember, graft to the right, counterintuitive, counterclock. Everybody thinks graft to the right is a little above the right. So if we clock to get into the right coronary artery, we must probably clock to get in the vein graft to right coronary artery. It is unfortunately wrong. A graft to the right coronary artery is counterclock. And it goes to my earlier idea about 180 degree in one direction doesn't lead to the same point as 180 degree in another direction. So this is a GR4 catheter. If you clock it almost 180 degree, it will tilt itself and elongate itself anteriorly and touch anteriorly the RCA, or it can touch anteriorly the vein graft to the left. That's why clock usually work for vein graft to the left. Conversely, the vein graft to the right often, not always, but often is a little more posterior, is on the right and slightly posterior surface on the aorta. If you keep clocking, you're not going to get it because the catheter is already elongated anteriorly. So you have to counterclock, and counterclock elongates that catheter posteriorly. 180 degree counterclock reaches you, elongates it more posteriorly. 180 degree clock reaches you and elongates you more anteriorly. So that's why often counterclock works. Now, not always. Sometimes that graft is more anterior and clock may work. But I would say 80% of the time, we need to counterclock as a first maneuver. If you keep counterclocking, it doesn't work, sure, there is no harm in trying clock. But the immediate reaction, graft to the right, is opposite to the right. It's counterclock. You got it? Everybody understand that picture is a very important picture, I think. Everybody understood that? All right. So graft to the right, we engage it here with a multi-purpose. Again, I do the view. This is the LAO view. I used to engage it. I use that to see the graft, and you can see it's very bulky and atheromatous without severely obstructive disease. Then the second view is a view that's good for the native. What view is good for the native distal right? As I described before, it's a cranial view, typically a P cranial view. And this is what we did here, a P cranial view, and shows you very well that PDA and the anastomosis of the graft to the PDA. So now let's map the anatomy of this patient. We did everything on him. We did all the graft. All the grafts are open, but that doesn't mean he doesn't have a problem. So he has patent LIMA to LAD that only fills the apex of the LAD. Retrogradely, there is a subtotal occlusion, and it doesn't fill the proximal diagonal. Luckily for him, those proximal diagonals have unobstructed flow through the left main prox LAD. He also has, and that's how you should report it. And I see no fellow or no doctor ever reporting grafts this way. That's how I like to report the grafts in terms of territory. So this is how we should report this patient. Number one, LAD system. Within number one, first idea, LIMA to LAD fills the apex antegradally with no retrograde filling. The proximal portion of the, and within that same idea, LAD, the proximal portion of the LAD and diagonal are filling via the native vessel with unobstructed flow. Or you can say with 90% obstruction, and therefore that territory is potentially ischemic and causing angina. Now, big number two idea, left circumflex system. Well, the left circumflex has a patent graft to OM2 that doesn't fill the rest of the circumflex. We have an occluded OM1 that fills via collateral, and that is ischemic. It's not receiving any graft flow. So that was our second territory, circumflex. It is partially ischemic because the graft is not filling it fully. If there was no obstruction here, if that OM2 was not occluded, maybe that OM2 graft will fill retrogradely into the OM1, but that's not the case. Third territory, and again, that's how you should report it, right coronary artery territory. We have a graft filling the PDA, but unfortunately that graft is not filling the rest of the native RCA. The rest of the native RCA is dependent on the native flow, through the native RCA. So that RCA, native RCA, is filling the PLBs. So we have patent graft to PDA and patent RCA into the PLBs. If you had a 90% RCA stenosis, well, that could be causing ischemia, even though the graft to PDA is open. Frequently in those graft to PDA, they do fill retrogradely. Frequently the disease on the right is somewhere here. So the graft to PDA fills retrogradely, not just the PDA, it fills retrogradely the PLBs. Not in his case, but luckily for him, the native right is open. Did everybody understand how this is really a very important idea. Did everybody understand how we analyze those cases, how we map the cardiac anatomy by juxtaposing the native as well as the graft filling, and how we report in terms of the three major territories? Do you want me to repeat that? And again, this is how I laid out this patient's anatomy. And again, this is how you should do it in every case and in every report. Because let me tell you here, this patient has 3 patent grafts, but that OM1 could be the source of his angina. So again, look at the native. I'm showing you his native. There is no circumflex. There is late filling of that OM1. OM1 is filling late, and you have an OM2 filling via graft, but we don't care about it. We haven't, I mean, we care, of course, but the OM1 doesn't care about it. It's not receiving anything from it. So what we did in this case, we actually opened that OM1, and that shows you, look how big it is. So that shows you that even though all three grafts of this patient were open, it was still useful to open the first OM1 to relieve his ischemia, because that was a decent sized territory that was causing him to have angina. So we opened this thing here so that now OM1 is being fed via the native. Did everybody understand that? I hope so. So look, I have I can go for about 5 to 10 minutes about general ideas related to graft. So I say you don't have markers, as is often the case, and you couldn't engage the graft. You tried the, let's say, REO view for a left graft, and you couldn't engage it, a common situation. One thing to do is to do an aortogram in the proper view. For example, aortogram in an REO view for a left graft. Or better yet, do an aortogram in two views, in an REO and LAO view. So you need to pick the better view to do your aortogram to see where that graft is, or to see if that graft exists, is open, but you missed it. Another thing is to do what I did here, is to kind of pull back the catheter while injecting all across the aortic wall and to see whether there is an occlusion. And you can see here, so we're pulling back and injecting to see whether we would see any graft. And we do that in two views. So I pull back with injections in two view. I find this more forgiving. If your aortogram doesn't turn out to be good or doesn't fill well the aorta, you will have to repeat an aortogram, and that's a lot of contrast. This is more focused injection with less contrast. So that's one thing you can keep doing if you cannot find the graft. I will show you here an example, and I want you just to know a reflex. So this is a patient to have a reflex for what the answer will be. This is a patient with LIMA to LAD. We're doing his native coronary angiogram, and this is what you see. What do you expect the LIMA to LAD to be? So you inject the native left, and you see the LAD filling very nicely. No competitive flow. Again, when you're doing a native angiogram in a graft patient, you always see competitive flow and late filling. You always look for those on your angiogram, competitive flow and late filling. There's no competitive flow in that LAD, and we see it well. It was an unnecessary graft, and you expect the LIMA to LAD to be atretic. So this is his LIMA to LAD. It shrinks, it negatively remodels, and it stops supplying anything because there is native flow preventing it from maturing and growing. Okay. So each time you put a LIMA or a radial graft, and sometimes a vein graft, but especially LIMA and radial graft, if you hook them on a non-severely diseased vessel, they will tend to shrink, constrict, negatively remodel, and that's what we call atresia. Okay, atretic LIMA. Now, I want you to try to guess, this is a graft to what artery? This is, again, another case. This is just trying to guess. This is a vein graft to which branch? And that will bring my next point, which is...
It looks like OM.
Excellent. And that will be my next point, is how do you guess the graft is going to what? And there are a couple of, yeah, you can say if you like.
I think like from the view and from the surface of the heart. Yes. So this view is REO, and it's actually near the diaphragm, not near the surface of the heart. So it's in the circ territory, not in the diagonal territory.
Excellent, excellent answer. That's how we know. Perfect. So one is a lot of time I use what view I use to engage it. You know, if we engage it in an REO view, it's probably graft to the left, but it is a graft to the left. But how do you distinguish graft to OM from graft to diagonal? And what Ahmed described is a perfect answer. I use generally two views. There are two views that help me delineate where the graft is going in case it is unclear. Ariocaudal view, as is the case here. In ariocaudal view, as Ahmed described, the OMs are toward the bottom of the heart, okay? Whereas the diagonals are on the border of the heart shadow. So this one, therefore, is a graft to OM, as you can see here. This is another case, graft to OM. It's on the lower part of the heart versus diagonal on the border of the heart shadow. Conversely, another view I use to help me is LAO straight or LAO-cranial. In LAO straight or LAO-cranial, the diagonal are over the body of the heart shadow, whereas the OM are on the margin of the heart shadow, okay? So ariocaudal, OM are on the bottom, LAO or LAO-cranial, OM are on the border, diagonal are in the middle. Sometimes they can look alike. You may have a high diagonal or a high OM or a ramus, and it would be hard to distinguish. But in this case, I call it high diagonal or high OM. And I say, you know, it probably doesn't make a big difference. Okay, everybody knew? Those are the two views that help you in those cases. I'll skip that. I will show a couple more ideas for those who can stay. How to use an MPLATS left. So graft to the left, I mentioned to engage the graft to the left, it's pointing up, but the GR4 is okay to do diagnostic. However, if you want to do an intervention on a graft to the left, you need something more supportive. Graft to the left interventions tend to be some of the most difficult interventions because you have very poor support in general. The graft usually points up way too much, and it's really hard to get support. It goes up, then it goes down. So you have, it's a very curvy graft. So you need a very robust supportive catheter that points up. My preferred is MPLATS left 1 to 2 or 1.5, depending on the size of the aorta. Second best is hockey stick. LCB is not great because it has a short tip and it doesn't provide you robust support. AL, on the other hand, provides robust support because it sits on the opposite wall of the aorta. Now, how do you engage with an AL? The left graft, and here I will show you. Those are very important steps. So it's a little different from using AL in the native vessel. You advance AL, again, we're engaging graft to the left, REO view. We advance the AL in its elongated form. We torque it around until it hooks that ostium that we're aiming to. And after it hooks that ostium, we push it to embrace the duck shape. And look how nicely supportive that becomes. It's sitting on the opposite wall of the aorta and it's pointing up. Okay, so you engage basically while it's elongated. It's unlike the native. You advance it in an elongated form, you engage in an elongated, then you push it in a duck. In a native use of MPLATS, we make it have that duck shape on the valve before we start torquing and engaging. Here you engage. After you hook the ostium, you push it to get that duck shape. Okay. This is another one of the final ideas here is the graft, what we call sequential and Y graft. I need you to know those. We see them often. So sequential graft is a graft that is hooked to two arteries sequentially. So it's hooked in a side to side to OM1 and end to side to OM2. Sometimes this portion of the graft occludes while this one remains open. Y graft or split graft, you have one main graft that goes to the OM and you have another graft attached to it. Rather than being this graft B, rather than being attached to the aorta, is attached to graft A and it goes to the diagonal. Those have some advantages. One, you need less veins and shorter veins in patients in whom you struggle to find veins. The surgeon, in cases where the surgeon struggles to find veins, those could be beneficial because you're using less veins. That's one. Two, you're increasing the flow across the graft. Patency of the graft is very much dictated by how much flow there is through the graft. So if you have, for example, a tiny OM1 and a big OM2, if you put a graft over the tiny OM1, that graft will likely occlude. But if you put a graft to OM2 and hook it on its way to OM1, that graft will likely remain open because its flow is driven by OM2. Even if OM1 is small, the graft will remain open because there is a big flow across OM2. You know, kind of same idea to the split graft. So those are the two ideas. It saves you vein and it can increase the flow across the graft and therefore increase patency in some cases. This is a case here of a jump sequential graft. So you can see the graft, it is attached to an to a ramus and to a distal OM. This is another view of it. It's attached to a ramus and to a distal OM. Okay. And again, in this case, you have to take more views. You have to tailor views to the ramus and you have to tailor views to the distal OM, which often requires, like I mentioned earlier, a cranial view to see well. The last idea I will describe here is how to engage from a left radial. Your maneuvering to engage the graft, vein graft through a left radial are the same as through a femoral. Same ideas about clock for left graft, counterclock for RCA graft. LIMA is different, evidently, because you're going from a left radial. This is the only case where I don't start with a native. I start by doing my LIMA images on my way in. And after I do my LIMA images, I get to the ascending aorta and I do the rest. I typically, when you're going from left radial, you need a catheter that is sharper than an IM. You need to go down with a very sharp catheter, then pull back. And as you're pulling back, you hook the LIMA and elongate that catheter. If you go with a catheter, if you go with an IM catheter that is sharp, but not sharp enough, as you're pulling it back, it will elongate and it will point too much in this direction. So I typically use the sharpest catheter, which is BC catheter, and pull it, and it will spread out and look down on the LIMA as I'm pulling out. Like I said, frequently it's either clock or counterclock. Frequently, I would start with a clock in this case. Same idea. You look at thyrocervical trunk, vertebral, and you try to aim in between and make the catheter point down. All right. Anybody has any questions? I will stop here. All right. Well, thank you all for attending. And all right. Thank you.